Thank you, Mr. Chairman, again, for the opportunity to ask some questions and to participate in the hearing. I, too, want to echo what was said. One of the things that I hope comes out of this is better use of telehealth and telemedicine. We have 3 regional health systems in South Dakota, all of whom have done some pioneering work in the area of telehealth technologies, and that is a way, I believe, that we can do a better job of delivering healthcare services, not just in our tribal communities, but in rural areas of the country. So I would encourage you to carry on with that. Secretary Wakefield, in your oral testimony, you noted the hiring of additional administrative staff, 2 new deputy directors, and created executive-level working groups. Is that correct? Now,
yes.
Did IHS consider using that funding at the local level to invest in additional providers, those that directly serve patients, or to address the emergent situation in Rosebud and Pine Ridge?
I would ask Mr. McSwain to speak to additional clinicians and administrators that have been or are being seated into those 3 facilities. I would say that the resources that we have committed at the local level from HHS, not from IHS, but from HHS, into that region are additional public health service corps clinicians, physician, nurse, quality improvement expert into the Great Plains area to focus very sharply on the current challenges that we have right now. So they are there on the ground. They've been on the ground, and they will continue to stay there as we work to stabilize and strengthen those 3 facilities and more broadly the area. With regard to the 2 positions that I mentioned, I think these 2 positions are absolutely critical. We have to have a much sharper focus on quality improvement if we're going to sustain and strengthen the quality of care that IHS is responsible for delivering. And that starts at the top. We've got a tremendous expert that we've brought to the table, fortunate to get her. And she has a plan that is operational, that can be operationalized. It's concrete. I'm not talking about it in the abstract. There are very specific strategies. I've looked at that plan. I've had people from CMS and the Federal Office of Rural Health Policy look at that plan. So her expertise at this level and that priority for that agency is one of our major strategies to begin to do the work, not just in the Great Plains area, but across Indian Health. And so this is a reset. This is a re-engineering of how we're doing our work and our focus on quality. I think those 2 positions at the executive level set the tone for what we need to be focusing on, making this a top priority. It is for us.
Well, I guess I would say in addressing the situation that, and I'm glad you're putting that kind of spotlight on it and focus, but I think it's important to remember that the solution to every problem isn't growing the administrative size of the agency. I mean, we want to get people on the ground that are delivering health care services, doctors and nurses, and in as much as you need somebody that's going to do this. And I hope that this time it gets done. Because, you know, we had in 2000, after the 2010 report, there was a position or a paper put out that had a strategy that was going to be implemented in the Aberdeen area. The Aberdeen area responded to that report with their own report about all the things that they were going to do. In 2013, we had another report about all the things that were going to be done, and none of the stuff gets implemented. So I guess my point is that when you're looking at these issues, clearly there are problems up the food chain, and there's not the sufficient oversight and follow-through and implementation and all that. And so I'm glad you are rightly focused on that. But I just think it's really critical that we get the help to people on the ground where we've got the needs that are not being met and the conditions that have been so well documented. Mr. McSwain, and I want to follow up with that because there was a lot of work done in 2010. The committee report created this Program Integrity Coordinating Council that was, you know, to make recommendations for changes within IHS. As I said, they reported. The then Aberdeen area responded with specific plans to better the region. Who was responsible at that time for compliance with the July 2011 plan?
I'm trying to, you're testing my memory, but let me just simply answer the other question you had about staffing at the local level. Just bear in mind, we're talking about a 37% vacancy rate. How are we actually filling those positions? We're doing it with contractors. And we'd like to get away from the contractors, and because the contractors are costing us at least triple, and that's another point. But getting back to your question about the Program Integrity Coordinating Council's oversight and the actual work group that went into that, during that time, it was actually, I may have been that in my previous job. I may have been the Deputy Director for Management Operations, and therefore was actually overseeing the activities going on out there until I was changed out. But that particular report focused in on helping the agency move ahead with addressing the report itself, the report findings, the some 19 findings.
Well,
And we walked down through all of those items, and some of them, we actually have made very good progress on some of those items. Some of them are still very, very challenging.
Well, to your knowledge, are the reports that are submitted on the 30th of each month, which is something that was called for by each hospital outlining the level of compliance with the CMS conditions of participation, which was a requirement of the July 2011 plan. Are those reports submitted, to your knowledge?
Yes, they are.
On the 30th of each
Yes.
month? Okay. Well, then how is it possible that 3 hospitals in the Great Plains area have failed to satisfy the conditions of participation? I mean, were IHS officials in the Great Plains area just rubber stamping these documents? How did this happen?
They weren't rubber stamping them so much, Senator. They were taking them and they were processing them through. What happened on the surveys is that, and I'll certainly defer to Mr. Slavic and Mr. Hamilton, but there were times where we actually achieved satisfaction on the surveys, and then, as I think Mr. Hamilton mentioned, then we failed again. We fell back, and so that was a year later. So we achieve, and then we fail, and that's been a cycle. And what I think Dr. Wakefield is talking about is we want to sustain why we're up there and continue to move forward.
Well, and my time has expired, Mr. Chairman. There are some questions I'd like to, if it's possible, submit for the record. But I just would say in closing that in response to Secretary Wakefield, your comments about creating a structure or a model, that this time it's got to work. I mean, Mr. McSwain, even in response to the 2010 report, we're not sure exactly who was responsible. And what I'm saying is there has got to be accountability. There has got to be chain of command. The buck has to stop somewhere to prevent these sorts of things from happening, and to ensure that the conditions that we've been finding and that CMS is responding to just don't happen again. And that's going to take a lot of work on a lot of people's parts.
Couple of additional
I just have
questions,
one
Senator
quick
Heike.
question, Mr. Chairman, if you'd just
Please.
indulge very quickly.
Please go right ahead.
Mr. McSwain, because this came up a little earlier and it was sort of in a passing sense, but I want to ask the question. To your knowledge, is IHS still discouraging IHS employees from communicating with Congress and tribal governments?
No, we actually have a process whereby if they're going to make a statement to folks, that we know what they're going to be saying, that it's accurate and correct. But aside from that, there's no prohibition at all.
Well, I would just say, I hope you'll revisit this with your department, because I will tell you personally, from my staff's experience, that we continuously have issues gaining information from IHS employees who observe some of these incidents but are fearful to step forward. It was an issue that was identified in the 2010 committee report, and I would just like to remind you and your entire staff that it is against federal law to interfere with an employee's right to speak with Congress. And I just think had some of these employees been able to come earlier, we might be having a different hearing today. I would just direct this to the panel, but you heard obviously today earlier, Mr. McSwain stated that the IHS is committed to a transparent working relationship with Rosebud, Oglala, and Omaha, Winnebago tribal leadership. To date, how transparent do you feel the IHS has been, and what recommendations would you make to improve IHS's transparency with tribal leadership?
I'd like to address that. I'd say we've made great strides from last July when we first learned of our CMS termination through the media. The former area director was in our tribal chambers reassuring us that everything was fine. So we've come a long way since that time. We have weekly calls, we have a monthly face-to-face, but we begin to feel like it's just lip service. You know, we're not seeing the improvements that we'd like to see quick enough, and like I was mentioning, the blizzard situation. So there is not complete transparency. We ask for things. Some of the questions seem repetitive, like we ask for them over and over again. So in some senses, we're being entertained, but we're not getting the solutions that our community needs and that we need to provide to reassure them that the healthcare is back on track.
Do you feel that IHS is responsive to the concerns of the Tribal Council, Tribe, and Tribal Chairman's Health Board when they bring issues forward? Do you get a...
I think collectively between the Tribal Health Board, NIHB, the National Indian Health Board, the Tribal Councils, it's taken all of us to work together to get to this point. You know, each individual agency, I don't think, has been completely, have completely been effective or gotten the answers that they deserve or have asked for.
Senator, in the Billings area, under Dorothy Dupree as acting director, she allowed the tribes to be ex officios on the governing boards for the facilities. And in my testimony, written testimony, I've asked that they allow tribal representation to be voting members of these governing boards over these facilities so they know the ins and outs of the accreditation standards that are needed, the reporting standards that are needed in managing a medical facility. That was a solution, and right now we're asking for full voting authority to be members of these governing boards.
Ms. Weston?
Yes, Senator, you know, I believe that the IHS needs to be more, I guess, based on consultation. I believe that they need to do more of the consultation piece to the tribe, especially the tribal leaders. I think one of the senators talked earlier about a communication breakdown between the staff here in DC and the Aberdeen area and down to the local service units. I really believe that sometimes I believe communication is not happening between the staff here in the DC area and down to our service unit directly at times. And I think there is a communication breakdown, but I really believe that the tribal leadership needs to be involved in a lot of these meetings. And I know that what Mr. Kilsback mentioned is the governing body meetings. You know, I know that representation from the tribe all the time is the chairman of the tribe or the chair of the Health and Human Services Committee. So I believe that sometimes we are notified and there is times that we're not notified. So I really believe the consultation piece needs to really be reinforced to making sure that IHS is consulting with tribal leadership, especially when it comes to budgetary or any other important decisions that are based on our IHS service units. That needs to continue all the time. Thank you.
Senator Thune, I think even since the CMS review and we had a plan of correction in Rosebud that was accepted by CMS, you know, there's still continuing to be practices that continue that just doesn't give us any hope that things are being taken seriously. And I feel that there just needs to be more direction as far as the air, you know, up the chain, where they need to be more actively involved and help us work towards getting our ER services back open. Like the other day It was supposed to be reviewed and see if we couldn't open the first part of February here, but, you know, from what we're hearing, by no means are we ready for that. So, in answer to your question, I just feel that there's a lot of work yet to be done. And in my testimony, when I mentioned our resolutions between the committee and Congress, besides budgetary woes that we fall on, listen to the tribes. Nothing better than your staffers are great. Ms. Hovland, she's a great asset in listening to us and addressing and letting you know how things are. And the resolutions, you'll be seeing some of them coming from us, but they were addressing some of what we want to see for the future. There are short-term, but there will be long-term solutions, but we need your help, and you'll see that in the next 10 days or so.
Thanks, Glenn.
Thank you.
I just very
Go right
quickly,
ahead.
my
Please,
time's
go ahead.
expired, but.
Go right ahead.
Ms. Weston, you mentioned in your testimony air ambulance flights that place a significant burden on the service area's budget. And recently, I've been told that IHS doesn't have a flat contracted rate with providers in the area. Since this is clearly placing a burden on the operating budget, do you know if IHS has been exploring ways to standardize these flights to ensure continuity when it comes to billing?
I think the area of the air ambulance is kind of a concern, I guess, a while back with the HHS committee as well as leadership, was we only had one air ambulance that was picking up our patients and taking them either to Rapid City, Sioux Falls, or Scottsbluff, Nebraska. And so we had inquired about what is going on. We only have one air ambulance. And come to find out was that there's other vendors, I guess, you know, that also transport patients. But according to what the acting CEO mentioned was that they call on one air ambulance because they have a contract with that air ambulance according to the way the structure is with the Aberdeen area on how they RFP out vendors, I guess, to pick up patients within the Indian Health Service. And so they utilize only one air ambulance right now. And the cost of it, we were told, was enormous. And we did get copies from the acting CEO on the amount of money that we were spending. And I will tell you that it is quite high. And I think that she did mention that it does take a lot from the base budget of the Indian Health Service at our service unit.
Okay, thank you. Thank you, Ms. Weston. Mr. Chairman, thank you, and thank you so much for being here today. Very, very helpful.